Hello, everyone. So today I'll be talking about hemolytic uremic syndrome, in short, HUS. So the first thing I want you to understand about hemolytic uremic syndrome is that it's a thrombotic microangiopathy. So what do I mean by this? What I mean by thrombotic microangiopathy is that this condition causes microthrombi. This microthrombi spreads across the small vasculature in the system, such as the capillaries, the arterioles, which in return cause most of the signs and symptoms that you see in HUS. So I'm going to walk you through HUS, and I also have a case presentation to help you understand this better. First, I want to highlight the causes of HUS. There are two major causes. First is caused by a sugar toxin, and this occurs mainly in the young people, usually from 6 months to about 4 years. So there are two major bacteria that produce the sugar toxin. One is the enterohemorrhagic E. coli, while the other is the Shigella dysentery. So this makes up 90% of the causes of HUS. And like I said before, it occurs mostly in children. And then the other causes makes up about 10%. This is less common. It can be caused by autoimmune diseases like SLE. It can also be caused by some other bacteria like Streptococcus pneumoniae and some other malignancies, but those are less common, and I won't be focusing on those in this discussion. So for you to understand HUS and for you to be able to identify this disease condition, you need to know that HUS is composed of three triads. The first is thrombocytopenia. The second is acute kidney injury. And then the third is microangiopathic hemolytic anemia. I don't want you to cram this. I'm going to walk you through the pathophysiology so that you can easily remember this while answering a question, even while you are on a clinical rounds. So first, for the pathophysiology, I want you to understand that when a child is infected by E. coli, enterohemorrhagic E. coli or Shigella dysentery, when a child is infected by this, it can cause bloody diarrhea. So when this toxin, the sugar toxin I spoke about earlier, when this toxin gets into the body, it can release cytokines into the body. These cytokines cause vasoconstriction, and they also cause activation of the platelets. These platelets together form microthrombi. There's something about this thrombi in that it spreads throughout the body, especially the kidneys. It spreads to the capillaries of the kidneys, which is the glomerulus, and it can cause acute kidney injury. So when we look at the triad, first is thrombocytopenia. We know where thrombocytopenia comes in. When the cytokines are released, they cause microthrombi, which can deplete the platelet levels. And then this microthrombi spreads around the body, most especially the kidneys. And when they spread to the kidneys, they reduce blood flow to the kidneys, they reduce the GFR, which can cause an acute kidney injuries. And then lastly, the last triad is the microangiopathic hemolytic anemia. These thrombi, like I said earlier, they affect little vessels. So when they occlude these little vessels and red cells are trying to pass through them, they experience difficulties, and this can cause sharing and lysing of red cells. This sharing and lysing of red cells gives the typical hemolytic anemia you see associated with this condition. So of course, you know the lab findings, there will be thrombocytopenia. As for the kidney injury, you'll see an increased urea, you see an increased creatinine. As for the hemolytic anemia, you see features associated with hemolytic anemia, such as reduced hemoglobin, reduced haptoglobin, increased LDH. You also see an increase in indirect and total bilirubin levels. So one last thing I want you to understand about this topic HUS is that the treatment is generally conservative. You don't use antibiotics to treat them. What you need to do is to hydrate the patient effectively well to help with the kidney injury. You can also transfuse blood if the PCV is below a certain level, or even give platelets if there is severe bleeding. So I'll just quickly walk you through this case so that you get a better understanding of HUS. So this is a 4-year-old boy that was brought to the clinic for evaluation of pallor and increased lethargy. From this, you can already know that there is some form of anemia going on. 1 week ago, he experienced abdominal pain, vomiting, and bloody diarrhea. So, like I said earlier, this is usually caused by E. coli or Shigella dysentery. Usually, this causes an invasive gastroenteritis. So, you can see that this child experienced gastroenteritis 2 days ago. And then you can see that he's pale, the pulse is high because of his pale, of course. Respiration is 30, blood pressure is 95/50. On examination, we have scleral icterus. Remember that hemolytic anemia increases the bilirubin level, which can give us scleral icterus and also jaundice in other parts of the body. They can also see from the lab studies the hemoglobin is low, which is expected anemia. The mean corpuscular volume is normal. Of course, we know hemolytic anemia is a pneumocytic type of anemia. We have the leukocyte level, which is high, which indicates an ongoing infection. The platelet level is low. The prothrombin time is normal. The partial thromboplastin time is also normal because issues affecting the platelets don't raise these levels. These levels are raised by issues affecting the factors in the body. And then lastly, we have the urea nitrogen and the creatinine high, which indicates an acute kidney injury. We also have bilirubin. Total bilirubin is high, which is a sign of hemolytic anemia. And then look at the blood smear. The blood smear, we have schistocytes, like I spoke earlier about. If you smear the blood in hemolytic anemia in these patients, you can often see schistocytes, which occurs as a result of red cells shearing as they pass through a small vessel. So from this, you can see that we have a triad here. Number one is the thrombocytopenia. Number two is the AKI, which you can see here, acute kidney injury. And then the third is the microangiopathic hemolytic anemia. So of course, the most likely diagnosis here will be hemolytic uremic syndrome. I hope I'm able to make you understand this. Thank you.